Today we're going to be talking about pediatric hypertension. We're just going to do kind of a brief overview. We're going to start off with a case. So for our case, we have a 12-year-old male. He has a history of asthma secondary to bronchospastic dysplasia, also history of autism, intellectual delay. Referred to the ED from his pulmonologist because he had hypertension to the 180s to 190 systolics over the past like 3 visits. On arrival to the ED, his blood pressure is 188 over 100. His heart rate is 95, afebrile. Vital signs otherwise pretty unremarkable. Physical exam, he's intermittently fidgety, developmentally about more so in age 5. He's kind of tall for his age. His lungs are clear. He's got no stridor. Slender. His belly is soft, non-tender, non-distended. He's got a normal GU exam. He's uncircumcised, kind of about a Tanner stage 2. As far as his birth history, it is remarkable for the fact that he is X 32 weeks and 5 days, and he did have an extended NICU stay. We even delved into some family history. He's got some grandparents with hypertension, but otherwise, his family history is pretty non-contributory. So before we get into this case a little bit more, we're kind of going to just talk about some generalized causes of pediatric hypertension. Kind of the first one being white coat hypertension. You think of this in adults, adults getting nervous when they're approached by a healthcare provider. But this can also be true for kids, right? You have a screaming 3-year-old, you're not their primary caregiver, a nurse or someone is trying to assess their blood pressure, people are touching them, they hate it, you look at the vital signs, and the nurse puts crying in parentheses, or, you have your 6-year-old and, they've been waiting for a while in the ED, and they've kind of spent their time, running around, jogging, whatever the case may be. And so when the vital signs are taken, their blood pressure is a bit elevated. Kind of moving on. So we sort of talked about that. Pharmacologic causes of pediatric hypertension. So it's really good to just kind of review any kind of medications the kid is on. So history taking here is very important, right? Are they a teenager and on OCPs? Are they 12 and they have a pretty severe Starbucks habit? Do they take Ritalin or another stimulant for their ADHD? Or are they like a 5-year-old and they kind of had a stuffy nose recently and mom is given maybe a decongestant for their URI? Kind of talking about that, before we talk about the differences between primary and secondary hypertension, we just kind of want to talk about best practices in terms of measuring blood pressure in the ED. So wrist versus arm. We're trying to figure out how do we know that we're getting good blood pressure reading. So there's actually been a few studies saying that there's maybe a benefit for doing wrist blood pressure versus arm blood pressure. The advantages being that they're smaller, it's easier to be placed, and then wrist diameter isn't really affected by BMI in the same way that it is for an arm measurement. Unfortunately, there's kind of limited data there. So for right now, the recommendation still is for the arm. Usually it's recommended to use the right arm. And then the best practice is that the child should be seated in a quiet room for 3 to 5 minutes before the measurement, with their back supported and their feet uncrossed on the floor. The patient observer should not speak while the measurement is being taken. I mean, obviously in RED, I'm not sure if that happens ever, right? Like usually it's probably happening in triage, or sometimes, they'll be sitting in the ambulance triage area while other ambulances and other kids are coming in. So there's something to be considered, if you have an abnormally elevated reading, that we're probably not getting kind of best practices in terms of actually measuring the blood pressure. Also very important for kids, also for adults, but especially kids, because there's quite a wide variation between sizes, is getting kind of the right blood pressure cuff. So of course, if they're between sizes, the general recommendation is actually to use a larger of 2 cuff sizes. They say although that a cuff size is too small, it can give you a falsely elevated reading. Cuff size that is slightly too large still will provide a pretty accurate reading. And then now that you've done all of the things, you made sure that the blood pressure cuff is the right size, that you've got the patient quiet, what are the actual blood pressure measurements that we are looking at? So defining hypertension. So we'll just start kind of on the age 13 and greater side, just because that's pretty simple. The blood pressure standards are pretty similar to what they are for adults. So normal blood pressure is considered 120 and over 180, and elevated, similar. For children 1 through 13, of course, things are a little bit different. You have to take into consideration age, gender, as well as height, and then calculate this to find out what is greater or equal to the 90th percentile. And then usually here, stage 1 will be considered plus 12 millimeters of mercury, or whichever one is lower. So it's pretty complicated. This is kind of more so used by nephrology. And this is like what we call a normative blood pressure table. Probably a little bit too in-depth for what we would do in the emergency department. Because we don't do that, we usually just use screening blood pressure values. So this is basically a simplified table that's designed as a screening tool to identify kids and adolescents who need further evaluation of their blood pressure with repeated blood pressure measurements. So technically, these are measurements that should not be used to diagnose hypertension, but these are kind of good cutoffs to use to figure out which kids need to be referred for kind of further workup. So diagnosing and when to treat. So again, this is a little bit kind of beyond the scope of the ED, but something to kind of mention. So again, most of the time you want at least 2 to 3 repeated blood pressure measurements on separate occasions before you make a diagnosis of hypertension. And so with each one, even if you have one elevated blood pressure reading, their recommendation is for like lifestyle counseling, for weight and nutrition. If you're having like a second measurement that is also elevated, depending on how high it is the first time, you can either repeat this in 6 months, if you're just slightly elevated, or within 1 to 2 weeks, or even like within 1 week, if you're concerned that this is like stage 1 or stage 2 hypertension. Also for this, depending on kind of how high it is, you want to check upper and lower extremity blood pressures as well. This is kind of just to rule out coarctation of the aorta or anything else that might be causing unequal blood pressures. And then, they also recommend here, this is from the AFP, ambulatory blood pressure monitoring as well. But essentially, you're not going to get to the initiate treatment phase with kind of these stage 1 and stage 2 hypertension measurements until at least your second or third ED or outpatient visit. Next, we're going to kind of talk about primary hypertension. This isn't really the main focus of today, but I think this is obviously the most common cause of hypertension in adults as well as children. And so bears mentioning. So in terms of primary hypertension, the risk factors are similar for children in the same way they are for adults. So being overweight, diet, foods that are high in salt and processed foods, low fruit and vegetable intake, low physical activity, as well as poor sleep. According to the AFP, the overall prevalence of hypertension in childhood is 2 to 5%. And there's now quite a great body of evidence that high blood pressure in childhood is also associated with adult rates of cardiovascular disease. Before the 1970s, actually, blood pressure wasn't really commonly measured in asymptomatic children. And so therefore, whenever they did get a measurement, they were usually pretty high. And at the time, the adult threshold was like 140/90 for hypertension. So these kids really had like severe disease. And a lot of times this was secondary to kidney disease or some other type of cardiovascular abnormality or endocrinopathy. So at the time, it was actually assumed that like childhood hypertension that was primary of origin didn't really exist. So far, the other thing that to mention here, actually, in terms of modifiable risk factors, which are a bit different for, I wouldn't say different, but specific for children, poor sleep, so encouraging sleep hygiene, OSA, which can be obviously evident in adults as well, is really important in kids too, just because there are certain conditions, certain levels of prematurity, as well as conditions like autism that can lead you to have like floppy airways and laryngomalacia, which can also cause increased blood pressure. The thought here is that during sleep, patients with OSA repeatedly subject themselves to intermittent hypoxia, They have intrathoracic pressure increases and microarousals, which result in the hyperactivity of the sympathetic nervous system, and then essentially higher oxidative stress and a pro-inflammatory hypercoagulable state. So just something to be aware of, especially if this is a kid who's, had recurrent strep infections or, a tonsil or hypertrophy. Adenotonsillectomy has actually been proven to be a pretty effective treatment in eliminating or reducing hypertension in these patients. This is just a picture of ambulatory blood pressure monitoring, which is recommended in the other guidelines. I'm not sure to what degree this is actually done, but this is kind of the device that's used. So we kind of talked about primary hypertension. We did talk about one cause of secondary hypertension, the sleep disordered breathing. Now we're going to go into like renal diseases and other genetic syndromes that are associated with hypertension. So causes of renal vascular hypertension. So other than primary hypertension, renal vascular hypertension is responsible for like 5 to 25% of hypertension in children. And then secondary hypertension is actually more common in pre-adolescent children, and then mostly caused by renal disease. So some of the causes, aren't able to really get through all of them, but some of them were touched on earlier. Renal artery stenosis, these are in conditions like neurofibromatosis and Williams disease. Essentially in these conditions, there's high blood pressure that's caused by like a narrowing or blockaging of arteries that are supplied to the kidneys. You get like physiologic stenosis, and then high blood pressure caused by disruption of the renin-angiotensin syndrome. In some of these cases, you can refer them to nephrology, or vascular for transluminal renal angioplasty or other kind of interventions. And then this was also talked about by Mame, and I believe Taylor as well. Acute glomerulonephritis and glomerular disease is also an important cause of renal hypertension. Important to note, it's really not the degree of hypertension, but the rate of hypertension and kind of the acuity of it that essentially causes the most issues. So essentially, in kids with acute glomerulonephritis, the blood pressure may be considered relatively mild. However, if the rate of rise is high, the kids can develop encephalopathy at blood pressure levels that you would consider like mild in a hypertensive adult. Importantly, again, the causes of acute glomerulonephritis that were mentioned before, so strep throat, impetigo. Other causes of acute glomerulonephritis are bacterial endocarditis, as well as acute HIV infection. So all things to consider. In addition to that, we have like our obstructive uropathies, as mentioned by Dr. Rallo. So I think I have a few slides going forward with some pictures of posterior urethral valves. And then additionally, like prematurity. So prematurity independently is a cause of hypertension, as well as low birth weight independently. But another risk factor for hypertension in children that are premature are kind of extended NICU stays. And in these extended NICU stays, a history of having an umbilical vein or umbilical artery catheterization that can also increase your risk of hypertension. In umbilical vein catheterization, there's increased risk of portal vein thrombosis, which can lead to portal hypertension. And then in umbilical artery catheterization, you can have renal infarcts acutely, but you can also just have global vascular endothelial disruption that can also cause kidney injury. So we're concerned about causes of acute nephrovascular renal injury in the ED. Maybe not acute, but causes of nephrovascular kidney injury. So another tool at our disposal, as always, is ultrasound. So these are just a few of the pathologies that we can identify with our ultrasound in the ED. So I believe one of my colleagues touched on it before, but nephroblastoma or Wilms tumor. So this is the most common cause of pediatric renal cancer, and the most common pediatric cause of abdominal cancer, slightly more common in girls than boys, and then more common in African Americans. And then usually if you're able to identify this and have it treated, the removal of this tumor can lead to normalization of blood pressure. Next one, we won't spend time talking about this, but as discussed by Dr. Rallo, here's a picture of posterior urethral valves and a keyhole sign. So something else that you can identify on ultrasound that is a cause of uh, renal or renovascular hypertension. And then this one usually is probably diagnosed, you would hope, by your pediatrician or at someone else at some earlier point. But autosomal recessive polycystic kidney disease, which is the juvenile form, is also something that you can technically pick up on ultrasound, as opposed to the autosomal dominant form, which is more common in adults. The cysts that you see are usually smaller in size. And then there's like a loss of distinction between the medulla and the cortex. So if you're concerned for renal vascular hypertension, what's your workup? So very similar to what was mentioned previously, you want a CBC, a CMP, UA, urine protein creatinine, renal ultrasound, bladder ultrasound, and then your nephrology consult. There are also just kind of some studies saying, or looking at rather, what the indications are for like EKG, echoes, and chest x-rays, if you're concerned for hypertension in these patients. And so far, the studies have shown that there has not been really good evidence to show that these tests are useful because there's pretty low sensitivity to detecting cardiopulmonary damage in pediatric patients. So this is just trying to look at kind of best practices for kind of a further workup, depending on what you're concerned about. So this is from the AAFP, and these are their guidelines. So for all children with confirmed hypertension, they recommend BUN, CBC, electrolyte levels, renal ultrasonography, urinalysis, urine culture. And then again, if you're concerned more so about primary hypertension, especially in overweight children, they recommend fasting glucose levels, lipid panels, and then there's not really, this is more of a consensus statement, but they say if you have confirmed hypertension and you have hypertension and diabetes with renal disease, then they do recommend echocardiography and retinal examination. Although the evidence on this is like a grade C. They also recommend polysomnography if you're concerned for disruptive sleep disorders. And then going back to our tox area, if you're concerned that this is our pharmacologic, to also do a drug screen. So thinking back to our patient who kind of had pretty high blood pressures there, not necessarily in the range of severe hypertension, but pretty close to it. So severe hypertension, again, is defined as greater than 30 millimeters of mercury above the 95th percentile based on age, sex, and height, and then greater than 180 over 120 in those that are adolescents and approaching adulthood. So if you have a patient who has severe hypertension, what are your management options in the ED? So the preferred medications for severe hypertension in children ages 1 through 17 are typically labetalol, nicardipine, and sodium nitroprusside. Again, this is when you have signs that are concerning for end organ injury. These are things like headaches, dizziness, chest pain, palpitations, other things that were mentioned in Mame's lecture. But again, there's no consensus really on the best initial antihypertensive medication to use in children, mostly because most of the trials are based on adults and then extrapolated from there. Let's see, going forward, this is a little bit small, but this is basically kind of the pharmacologic therapy for oral medications. The medications that are used are pretty similar to those that are in adults. These are kind of their doses here. I'm not going to go through them in great detail. And then just kind of AFP guidelines in terms of managing high blood pressure in children and adolescents. This is kind of a schematic. So again, this is more so in the outpatient setting, if you're thinking stage 2 hypertension, then, you're screening for cardiovascular diseases, and then stage 1, kind of the same thing, but this is sort of the schematic in terms of different blood pressure stages, and, whether or not you want to initiate therapeutic lifestyle changes alone versus with medications. So this is kind of a summary of the key recommendations from the AFP regarding blood pressure management. So again, uh, a lot of these have a C rating, which is not to say that you shouldn't do them, but that they're basically based on consensus, usual practice, and expert opinion, and not necessarily based on really large data heavy studies. So again, this is kind of the screening test that should be done, C level rating of evidence. Also, they said all children with diabetes or renal disease, pre-hypertension, or confirmed hypertension should be screened for target organ damage via echo and retinal examination. Again, mentioned before, but kind of a C grade level of evidence. And then even things that do have strong evidence are that children and adolescents with CKD and hypertension should be evaluated for proteinuria. This one is strong. And then kids with CKD, hypertension, and proteinuria treated with ACEs and ARBs, also strong. Things that are weak. So again, like we talked about before, actually a weak recommendation in children and adolescents with acute severe hypertension and life-threatening symptoms. Immediate treatment with short-acting hypertensive medications should be initiated, and blood pressure should be reduced by no more than 25% of the planned reduction over the first 8 hours. Again, expert opinion on this is actually weak, not even moderate, but still at this time recommended. Sorry, I'm talking fast and a little bit running out of breath a little bit, but we're trying to get you out of here relatively on time. So kind of going back to our initial case, we did find out a little bit more about our patient's birth history. His NICU stay was complicated by urosepsis, as it turns out. He also had a history of umbilical artery catheterization. The pulmonologist who had followed him before had actually sent out some basic labs, and that is the reason he called patient and mom back for follow-up. The creatinine for this patient in clinic was 10. It had risen to 12 when they arrived to the ED. They were actually admitted to the PICU, which is where I first encountered the patient over at downstate. They did not do a bedside ultrasound in the ED, but he did end up getting an ultrasound formally. His ultrasound showed that his left kidney was normal, and his right kidney, though, was just hypotrophic, very small. There were no tumors or any cysts. They did do like a CT angio perfusion study, and they showed that he had decreased renal perfusion to that right kidney. He ended up getting a permacath placed for dialysis. And then they also sent a genetic panel to see if he was susceptible to any other diseases that would cause him to have hypertension. Initially, the thought process was, I'm sorry, I should also mention no IV medications were given to him to acutely lower his blood pressure, since this had been demonstrated in clinic over a course of a few visits. But before all of this, his blood pressure had been normal. The thought process with nephrology regarding this patient is that he probably had a remote insult during the neonatal period, either when he had the urosepsis or potentially with the umbilical artery catheterization. And I did mention that he was kind of tall for his age. So at some point he had been compensating well until he had a growth spurt during puberty, and kind of demand went up. They did send him for genetic screening. We didn't have those results available. Other than that, he had a pretty unremarkable hospital course. His mom was pretty upset. He had a lot of follow-up in terms of cardiology, as well as neurology, pulmonology for all of his complications related to him being premature. But mom had never been made aware that potentially, because of his prematurity, he could have issues with his kidney. He ended up going on dialysis. And again, mom was a little bit upset about that because she had made a lot of efforts in trying to get him to go to like a specialized school somewhere out in Long Island, and being on dialysis was going to interfere with that. But otherwise, he had some routine follow-up clinics for dialysis here, and otherwise was doing okay. He was started on oral antihypertensives, and his blood pressure was better controlled. Um, these are my sources.